Welcome, everyone, to Stories from the Field, building the liver movement from the bottom up. And this is part of the Fatty Liver Foundation's More Tomorrows Learn, Inspire, and Value for Liver Health series. This program is made possible by a generous grant from from Madrigal Pharmaceuticals. Um, I just want to see, Tiffany, we have everyone in the room now, so I think we can start. So this is the second webinar that we're having for the year, and it almost feels like the start of the year, but I couldn't believe it. We already like near half the year, so things are moving really, really fast. Before we dive into the content of this webinar, our disclosures are that what we give here is purely for education and informational purposes. Anything that you want to take here, please discuss it with your care provider or your PCP or your specialist hepatologist and care team on what path would be best for you to follow. Next slide, please. So I think it's always important to sort of keep in check the storm that we've been talking about, the perfect storm. We know that liver SLD or steatotic liver disease is the leading cause of liver transplantation in women in the United States. There's been a wide variation in diagnosis and care due to the lack of consensus. I think we're making good progress in that particular direction, especially with new technologies. Poor health system preparedness and response to provide appropriate multidisciplinary team care. It is a disease that affects so many parts of the body and a combination of so many comorbidities that it requires quite a multidisciplinary team. The approach we take at the Fatty Liver Foundation, certainly, and with many partner organizations, is the biopsychosocial approach. So, not understanding the disease in a single sort of silo or lens, but understanding it more holistically from a patient point of view. I recently added this point that understanding organ disease as part of a multi-system disease. And I think the data that's coming out that talks about the inflammatory milieu in the body, together with the various metabolic functions in the body that manifest in the liver as steatotic liver disease, is something that we're increasingly understanding. This, over the past 2 years, we have new medications to manage the disease, and certainly we don't see this in isolation, but we see this as part of a comprehensive care package. We know that an ounce of prevention is worth a pound of cure, and certainly addressing these diseases at the primary, secondary, or even tertiary prevention stage is going to save us lots more money than dealing with the complications further down the line. And then this is the 21st century's looming public health threat. And we talk about this often in the United States or Western Europe, where the lifestyle diseases, as we call it, with lifestyle inactivity, sedentary lifestyles, etc., are the big challenge. But what we're seeing now is that this is an issue around the globe. And many of parts of lower and middle income countries have dealt with the scourge of infectious diseases. And now with increased life expectancy, they're seeing these sorts of lifestyle diseases. Next slide, please. But for all these factors that made it the perfect storm, we also thinking that it's a storm no more, because we are seeing multidisciplinary teams. We have resmetirom and semaglutide now that have been approved for the management of these diseases. We're getting better at managing the comorbid risk factors, that is the diabetes, hypertension, cholesterol, metabolic syndrome, etc. The new nomenclature has sort of been a precipitant for new levels of awareness. We have non-invasive tests, so the gold standard of liver biopsy, I wouldn't say is altogether gone, but we have many more options now. We have a better organized patient community, which we'll hear more about. And then we also have not just liver disease in the lifestyle, but also the inclusion of alcohol use disorder. But there's still ongoing risks that we face despite all these positive issues or factors that we have. Next slide, please. And I think this is the biggest one that we have, that we are just at the tip of the iceberg. The diagnosed MASH patients that we have represent less than 5% of the cases that are formally diagnosed with MASH. And so, looking at the bottom of the iceberg, it's about getting to that and speaking with community-based organizations who are at the forefront of raising awareness, educating, and sensitizing is key to this. Similarly, we know the risk profile of patients with the comorbidities, and we need to normalize or routinize MASH screening as part of their routine management. And so this is the large target audience that we need to deal with, which is the undiagnosed SLD. Tiffany, next slide, please. And so, before we dive into the conversation with our experts, I just wanted to remind everyone of the 5 A's that we learn about in public health school on health access. And this is affordability, availability, accessibility, accommodation, and acceptability. And very often when we think about having a technology that's been approved, we think, the job is done. But that's just the starting point because we have to address all these A's to ensure effective treatment of our patient community. And the first thing, affordability, everyone thinks about it, it's about the drug price only. And it's not about that. It's about the impact on the patient and the costs incurred in them receiving treatment. I used to have a colleague or have a colleague at the Baylor College of Medicine who says to his team that he, as a professor, is one medical emergency away from bankruptcy. And when you start thinking about it in those terms, you then realize how vulnerable patient communities could be. Availability, the physical presence of necessary health resources, including qualified staff and adequate, well-kept infrastructure. This has been a really, really perennial point in the patient community. Even though they may have access to health services, they don't necessarily have the access required for liver health. Accessibility, geographic location. The founder of Fatty Liver Foundation often talked about how he was 250 miles away from a hepatologist, despite having good health services. Accommodations, we often talk about patients going to the health service, but we don't talk about the health service meeting patients. So it's understanding patients in their context and then acceptability. And I think we'll go much, much deeper into this on this call, the cultural and social comfort levels between patients and providers, including trust, respect, language, etc. And those are the soft issues that are the hard issues to deal with. So next slide, please. So we're delighted with today's guests, and I must convey apologies from Gina, who's the executive director of the Liver Education Advocates. Gina had to respond to a medical emergency and is at the hospital at the moment. She'll keep me updated on how things are progressing. So we're all sending, and it's not for her, but it's for someone in her community, and we're sending good energy and hope for positive outcomes from her situation. But we have Sandra Marrero Ashford, who's the Chief Executive Officer and Architect at Health Betterment Initiative. And we have Shane Stratner, who's the Health Education Coordinator at Health Betterment Initiative. So with that, Tiffany, we can go off the slides. Welcome, Shane and Sandra, to our Fatty Liver Foundation webinar. How are you all doing and how's the start of the year been?
I can go first. It's been great. I mean, well, I'm doing fantastic. It's good. It's always good to see how far we've come. I mean, just in 2025, we had done about 10,000 lab tests to raise awareness, and that includes diabetes, cholesterol, liver, and kidney function. But to think 10,000 with over 4,000 individuals tested in the DMV area, such an achievement. But we're right from the start. I mean, we've already screened about close to 2,000 people since the beginning of the year. So the start of the year has been great. We've been really busy, but thank you for asking.
Excellent, excellent. Busy is good. Yeah, Shane?
Yeah, hi. I've been really busy in a really good way. I'm feeling energized and focused. And I've just been talking to the CHWs, training them, talking to the community, and people are asking a lot of questions, and that's a good thing. So we are answering those questions.
Mhm.
Excellent. And as I was looking at the list of people who registered for this webinar, it was actually a really interesting mix of people from the community, patient advocates, people living with disease, community-based organizations, private sector, as well as academia. And so I want to also be cognizant that all sectors don't understand the acronyms we use. So CHW is community health workers.
Mhm.
Interestingly, I used to say, as the doctor was the functional unit for medicine, the community health worker was the functional unit for health. And that's looking much more holistically of people in their context. So HBI, Health Betterment Initiative, very interesting organization. Sandra, do you want to tell us overall what HBI does, where it's located, and its range of
Sure.
services?
So HBI started officially as a nonprofit in the DMV area in 2006. We used to be Health Betterment Hepatitis B Initiative. So when I came on in 2023, Miss Jane Pan was our executive director. And she called me and said, I'd like you to come and take my place. I used to be, before it was an outreach coordinator, but they're community health workers. So I used to be one in DC helping clients get testing for infectious disease. And so we actually started from there. And she was like, Sandra, I want to change the name, but I don't know what to change it to. And I said, well, we want to keep the acronym HBI. So I looked up, and betterment is a word. We went with Health Betterment Initiative, and that's how we started because HBI does more than just hepatitis B. So we do diabetes, cholesterol. And we started doing those testings, it was to eliminate the stigma of hepatitis B within African immigrant and API, which is Asian and Pacific Islander populations. And so we started with that, not thinking of MASH and MASLD at the time. It was just to be able to make people comfortable of taking an HIV test, taking a hepatitis B test. Because if you say we're going to do free hepatitis B screenings, at the African Immigrant Church, they're not going to show up. But if you say an overall health screening, they're going to show up. So what we do is we get CHWs, community health workers from different populations. And as you know, with MASH, MASLD, diabetes, cholesterol, everyone can use that test. But we really want to connect with the community. So we take community health workers from Latin American countries, African immigrants, API, Asian American and Pacific Islanders, to be able to connect with the community and bring the testing. So what we found as well is that the higher incidence populations for MASH and MASLD are Latinos. So we focus there on the education. Now we cannot diagnose MASLD or MASH, but we can educate. And we can also do diabetes testing. We do cholesterol testing because that is the key. And I got brought into this and I wanted to educate more. And that's why Shane's here as well. It's because my own brother has MASH and
Mhm.
he's in line to get a liver transplant. So that's how come. And he told me, Sandra, if somebody would have told me, about this, maybe I wouldn't be here. So it's like if there's one person like my brother, there's many other people like him. And he had insurance and he was going to doctors, but it was just something they missed. So now he's getting a liver transplant. He's doing good. He's losing weight. He's doing what he needs to do. But at the same time, people don't think if my diabetes goes unchecked, my liver could be impacted. They don't think about that. So it's our job to go into communities and to raise that awareness. But we're not just there with, I mean, education's great, but that's not going to move the community. We need to do the testing. So what HBI does is goes into supermarkets, goes into churches, goes into the populations, offers the testings, does the education, and then we follow up with a provider and give people the knowledge about their lab tests. So we're doing all of that in supermarkets. I mean, we were in a supermarket just the other day. In supermarkets, in churches, I mean, we go to the todos. And the good thing is that we bring our provider the following week so that he can go ahead and explain the results. So really, we're taking everything because why? Because a lot of the population at times they're like, I can't go to the doctor either. They don't have insurance, and we do insurance navigation, by the way, too. They don't know, they don't want to miss out on work or they don't want to
Right.
hear bad news. So we kind of are the answer to that. But like I said, we don't diagnose, we raise awareness. I'll let Shane talk about what she does as well.
Go for it. And Shane, I want to sort of also add to that question, which is, a lot of people outside of the community sectors, understand about technologies, understand about health systems and payers, etc. But at the coalface, at the point of care and delivery, they sort of stop at the primary care clinic, which is still part of the health system and the facility. And what you're talking about, I often use the term guerrilla screening, right? It's going out there and literally accosting people in supermarkets, etc. So meeting them in their context. And the Fatty Liver Foundation, in times gone by, a few years ago, when we ran the Sun study, screening of undiagnosed NAFLD and NASH, they actually went to like the Mexican embassy and the consulate because it was an enriched population. So what I also want to know, and Shane, you probably have a great knowledge on this, is what is the actual process? How does this happen? Like, I mean, it's not just about walking into supermarket with your test kit. There's a lot of coordination that happens, etc. So how does that happen? And then what are the types of tests that happen on the street level that you can do?
Well, I actually think that Sandra, since she is coordinating a lot of this, and I'm doing the education, but our what we do, our events are scheduled. And
Okay.
so we're not just pulling people off the street usually.
Yeah.
Sometimes we are in the shelters and we have people who can come in and sign up, but I'll let Sandra explain that better
Yeah, I
because
could do the
yeah.
outreach and then you can do the testing portion. So we'll tag team. So
Yeah, yeah.
basically, for the outreach, what we do is so we do infectious disease, in which I oversee the linkage to care side for HBI. I'm the CEO, but I'm also like I'm a graduate of public health. So this, I love to see it. And so like we use population data to go in, but with MASH and MASLD, we can screen everybody. So basically it's word of mouth. So for example, for the supermarkets that we're going in for Todo supermarket, our CHW Zonia had a connection there and they're like, can you guys come and offer testing here? And she was like, yes. And then we went there, did it one time. And then the manager's like, can you come to another Todo supermarket in Dumfries? And we were like, oh, okay, that's fantastic. We can go to all the Todo supermarkets. It's not a problem. And the good thing with that is people word of mouth, they're there once or twice a week. And then it was kind of like once we started keeping to go going and going, like there's a hospital around here called Inova, and they're actually wanting to work with us too now. So it's like word of mouth gets going, and people just want to join in and assist in any way they can. So they want to offer different screenings, but it's great to bring that service to the community because as you know about like the immigration issues too, a lot of times they're scared to go to publicized events, but where you're going to find them is in the supermarket. Everybody needs food, they're going to go there. We actually had an event too at a like a little restaurant, and they publicized the event because one of our CHWs had a connection there when they went around talking to people about what we do at HBI. And they actually had that. They came, they did the testing. And then what we also do, because of course, physical fitness is also great for health and also for combating diabetes too. So we were like, let's get culturally appropriate dancers to do a physical fitness class. So while they're doing the testing, they get the physical fitness class. And then when they come back the following week, to get their test results, they get the education. So it's all going together. And so it's basically word of mouth. And because we've been here for so many years, people know of us, people trust us. And I do have to say, we get funded by Maryland Department of Health, not just for this, but it's also saying like giving us little props. Like MDH is helping us. Now we're getting testing, not for this, but for infectious disease for Virginia Department of Health, and we also get for DC Department of Health. So having that partnership with the health departments really helps solidify our reputation as well. But I do say that the one thing is that we care. We don't just let people fall. And if they need support, if they need a CHW to go with them to the doctor, we're going to do that too. But it's word of mouth, and it's being here for so many years too.
Absolutely. So it's a recognizable brand, and then leveraging of social and community networks, and
Mhm.
then going to sort of focal points in the community, like the
Yeah,
supermarket and restaurant,
and
having
churches too.
established the trust and then scheduling
Yeah.
them as events. Okay, so there's an announcement about an event, and through
We
the
actually,
social networks, it sort
yeah,
of goes around.
we actually just give them the little flyer for the supermarkets. We want to be respectful because some people they're still kind of worried about ICE, so we don't want to do announcements on social media. It's just out of
Okay.
respect for people, so we just do it. And then the newspaper, the grocery store will pass out a little flyer. If they choose to put it in their Facebook or in their WhatsApp, they can do that as well.
Okay. Okay. And so then people are aware of it. And then what happens at the event itself, Shane?
At the event, we have people that come in, they sign up, register. We do everything electronically now. It's all digital. It goes directly into our database. And so our data manager can get everything she needs from that. Once they're signed in, then they get tested and they will, if we're doing infectious disease testing, they will get results right then. If there is somebody, Sandra can talk about this also, but if there's someone who tests positive for Hep C, they're going to get a confirmatory test right then and there.
Yeah, because we have a phlebotomist that goes
Yes.
everywhere too. They're there. Continue, Shane.
Yeah.
It's
And
Excellent.
okay. We'll tag team.
yeah, of course. So then when we're testing for chronic conditions, when we're doing A1C, CMP, and cholesterol, then we'll send the results to LabCorp and we will follow up with results to them. If the results are unhealthy, then one of our CHWs will call with the results. And if they don't have insurance, then one of the community health workers will help them find a clinic that has a sliding scale or will help them with getting insurance. So,
And
and
then at
Sandra, go
times,
ahead.
yeah, at times too, when we have an emergency, because sometimes even the clinics that are free clinics, they may not have the capacity. So thanks to some donations that we get, we also will pay for like an urgent care. There was one incident where we had a Mongolian couple. The wife, like she had unchecked diabetes and she was just afraid to go into clinics. So she called us and it was kind of an emergency. So we just went ahead and paid for urgent care. Like I said, the most important thing that we're here for too is being that bridge to sustainable care. That's why I think it's important to have like the solutions. We understand some people will not qualify for insurance. So what is the plan? And the one thing I say is when we're going to do tests, we better have a linkage. We better have a follow-up because the ones with insurance are the lucky ones. They get to go on, they can find we help them if they need us. And sometimes they have insurance and they still don't know where to go. So we help them there. But the ones without insurance, we go to the FQHCs, or at times we work with a great partner, Five Medicine, who also helps our clients too. So it works out well because for me, it's more about that person that does not have insurance, that does not know where to go, and has not had a test in years, and they don't know what's going on.
So it sounds like there's a screening and management pathway, and you look at the risk profile of the person, and then look at the pathway on the tests they take, etc. And then what's really nice is that there's the navigation and referral to care. And I like what you said. We don't drop our community, right? They
Yeah.
always follow through. And it is an all of community care approach for those
Mhm.
who are insured and those who aren't insured as well.
Mhm.
So it's a wonderful model, and with close liaison with the state health authorities in terms
Mhm.
of reimbursement, etc.
Yeah.
Um,
Oh, so
Shane,
too,
yeah,
sorry. So
go
the
ahead.
health department, they help us with the infectious disease. That's hepatitis B, hepatitis C, HIV, syphilis. So they can
Okay.
help us with that. But a lot of this is thanks to companies and pharmaceuticals, but also thanks to donations too for all this testing. So the health department, like, and that's one thing we need to raise awareness on is the fact that like chronic disease also needs, the testing needs funding too, not just the infectious disease, but we're grateful for anything. And that's what, donations and also foundation support has helped us too with the testing for chronic disease.
Um, okay, so I think that gives us a really nice picture of what HBI is doing
Hmm.
and all the services it's providing. So I want to drill a bit deeper into steatotic liver disease and muscle mash. And Shane, that's your role, right, as a health education coordinator for that. So, what's it like dealing with a disease that no one's heard of, or people may be walking around with and they don't know about it?
That is one of the things that people have not heard of it. We have to explain, we will go to the basics with it. We described fatty liver disease, how you get it, what happens, all of the conditions, the metabolic conditions that lead to it. And you can see people, they're like, my doctor has never mentioned this before. My doctor has talked to me about my A1C, about my cholesterol, about exercise, about eating, but they never mentioned the liver. And one of our community health workers actually told me that this is the gap. She told me that some people do not even know where the liver is. So we need to go back to basics with a lot of the education that I find. So I make sure that our community health workers are prepared and feel confident about going into the community to talk about MASLD and MASH.
Yeah, Shane does an every Friday session with the community health workers too.
Okay, so there's ongoing training,
Oh
etc.,
yeah.
of your community health workers. Okay, so someone comes in, right? And let's say now that there's a risk stratification you do. They add in their weight, their age, existing medical conditions, and then you do screens with A1C, cholesterol, etc. And you think that this person might be at risk for having steatotic liver disease. So what happens then?
So what happens then is that we will do the education because, like I said, we cannot officially diagnose anyone. And we
Okay.
also look at the liver, the kidney function, AST, LT numbers, and that's a concern too. If we see a trend there, diabetes, lipid panel, look at the numbers. And we can't diagnose, but we will just let them know this is something here. We're gonna let you know, educate them on MASH and MASLD, and then we actually either connect them with a provider for them to bring it up with their provider because they're the ones that will take it from there. And so they'll take it, but it's like it's helpful just because they may not have been aware because they were lucky. They walked into the supermarket, they got a test. They may not have walked into the clinic, but they walked in somewhere and they got a test and then they take it from there. We make sure that the education is there, but that the testing is there as well. So they could take their test results with the education onto their provider. A lot of them choose to do that. And if they don't, then we assist them with the provider and giving them like the talking points of what they need to talk to the provider with.
Okay, so that's very empowering for patients where they can actually ask questions
Mhm.
specifically around this. There was a raised hand on the participant list. It was actually another Sandra. Tiffany, can we unmute Sandra so she can ask her question if she'd like? I'm not sure if it was answered in the discussion, but let's see if she can come on. In the meantime, from your understanding of muscle mash, is there any other intervention that could be added at the community level that may be helpful for screening or getting closer to understanding where a patient's muscle mash status might be?
Yeah, so I was actually at ASLD and I participated in a massively, it was a little liver scan, what they did, and they said they could tell based on that machine. It just took like 3 minutes. And of course I didn't have it, but like one of the CHWs I with had something that she's going to follow up with her provider. Her numbers were high. But if community organizations had access to that machine, you're already building trust in like the supermarkets. With the proper, I guess, with proper staff that can explain the machine, because that's always important. We just don't want to have anybody running it. That would actually be helpful to have those machines. I forgot what it's called because I'm not like the technical person here. But
Right.
yeah, it was a phenomenal machine. Like, and he gave me my results and everything. It took 2 or 3 minutes.
And there's many companies now that have imaging devices. They
There
almost
you
like
go.
mini ultrasounds,
Yes, yes.
elastography that can do this. So we'll go into that a bit more, but we have Sandra who can unmute and ask a question. Sandra? Oh, I think she's muted. Well, let's see if we can get her back on mute. Oh, Sandra can unmute herself as well. Sandra. Oh,
Sorry,
there we
you
go.
referring to me, Sandra Talavera?
Yes, we can hear you now.
Oh, okay. My apologies. I thought you were speaking to Sandra Ashford. My question was, with this initiative, have we thought about actually um, talking with some of the stores about allowing us to do this on a wider basis? Because I myself encountered liver values that were high, and my practitioner wasn't concerned. And somebody who was trained in nutrition many years ago, I never heard about MASH until it was really a late stage diagnosis. And it seems that no preventive mode of thinking is there for any of the physicians. So therefore, we all go on thinking we're as healthy as can be until things are really in a crisis mode. And I think it's something that this initiative that you have is really the only way we're going to be able to get any kind of footing on this diagnosis, because the medical community isn't in the mode of thinking preventively.
Mhm.
Excellent question. Sandra, do you want to take that?
I mean, no, I
Ashford.
totally
Yeah.
agree. I mean, like I said, the story from my brother, and then imagine that it's like, and you have individuals that, like she said, nutrition, she knew about it. She can, she can ask those tough questions, but a lot of times the communities we're dealing with, they won't walk in. So if they're not walking in, they don't have the trust in clinics. They just don't. So I think just raising that awareness, being in places accessible, and just like, you know, talking about it till like their ears fall off, because you're gonna have to. I think that, like, some people think, oh, for some of our clients, diabetes is just, oh, I have a little high sugar.
Mhm.
That's how it's kind of, they minimize it because they don't want bad news. Nobody does. But we try to make sure that people understand this is preventative care. It's better to take care of it now, and we're here. We're right here with you. We're here with you. Then when the liver acts up, unfortunately, sometimes it's too late. And we've seen that with some of our Hep C clients, that they didn't feel anything. They thought they were fine. And even like individuals like my brother and other people we've met, they were fine until they weren't. And so I think that sometimes we need to be out there. And that's why it's important. We don't just wait for people to come to us or go to our webpage. We go to them, and we go to the most vulnerable too. So thank you for I hope I answered your question. Thank you.
I
Well,
also have.
And
will we be
um,
able to do this on a wider scale? For example, I'm in Texas, and HEB is an excellent place. They're the kind of store that I could see would be on the forefront of having people there to do the testing instead of giving out the wine. I think they would be the ideal place to really set the 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 footing on this subject. I think they would be on the forefront, and they have dietitians on staff.
Great idea.
Yeah, I think it's great. I mean, we're
Yes.
only in the DC, Virginia, and Maryland area, but I actually think this is scalable anywhere. All you need is the phlebotomist, different individuals who speak different languages. And then you also need what's it called? A provider. A lot of people have insurance. So when they have that, that's good. But it's like you need those FQHCs for those that don't have insurance, or the sliding scale, because it's most important. The testing, the phlebotomist, the team, that's the easy part. It's the linkage to care. That is the hard part, especially for those that do not have. So if you have a provider that's willing to take individuals on a sliding scale, some people will pay if they don't have insurance, they can pay, or donations can support something else. I think it's scalable anywhere.
and I think there might be a really important conversation that could be had with supermarket chains that are across the country,
Yeah.
and draw up those sorts of partnerships where it can happen. There were 2 points that I did want to also touch, um, uh, because very often, and we have seen this, patients reported, especially with primary care providers who didn't know much about steatotic liver disease. Oh, don't worry about it, and even if we had to pay attention to it, there's no treatment for it. Well, now there is treatment,
Hmm.
right? And I think what you're doing when you're giving your patient your fact sheet and the questions to ask their provider is you empowering the patient to
Yes.
take on their doctor and say, no, no, I need to know
Mhm.
about this. Um,
Yes.
the other thing I think with prevention is so much about prevention is about behavior change, right? And that's not necessarily just a mental thing. It's or a cognitive, rational thing. It's emotive. It's experiential. And I wonder if the community health workers in, for example, a supermarket walked the aisles with someone and say, "This is good to eat. This is not good to eat," and help them with dietary choices, because diet is so central to all of this.
Yes, we actually have like a nutrition class too that we offer. We had the George Washington University nursing students doing one. We had one of our community health workers doing one to use, like, for example, they would take ethnic foods and make it a healthier way. So we were doing that, and that was important to being in supermarkets as well. So I
Right.
think that, like you said, diet, exercise, it all comes into play. So we try to give them as much information as we can, but we actually work with them as well with the nutrition class, which I really like. Shane, do you want to add into that?
Yes, so one of the classes that I do with the CHWs is healthy eating and how to make good choices. And we cover all of this. We even cover how to read the back of a food label, how many, so you can look at something and see how many grams of sugar are in something. So I think this is all really important for our community health workers to know when they're out there. And I actually have given, just yesterday, I sent some materials to one of our Spanish speaking CHWs so she could give that to her community. She says that when it comes to diet, they didn't understand. They eat a lot of tortillas, she said, rice, she said. And I found something online that this is perfect and sent that to her. So I'm continually uh, getting education to them so that they can present it. And I'll go back and ask them questions. Did you understand that? You have any questions about it? What can I
De
talk about?
Definitely. And it was important to bring Shane on as the education coordinator because I tell the CHWs, like, we can't just go out there, hey, here's a test here, pass out a flyer. That's not enough. They need to know what is it, all the information about the test we're offering. If you're not educated, you cannot be out there. You just can't because when the client has a question, you can't just look like, oh, I don't know, let me call Shane. You got to figure it out. So she does these weekly classes and she's wonderful. And it's important for our CHWs, especially in public health, to have
Right.
that education. They don't all have public health degrees, but it's like it's a certification that they should have when they're talking about these topics.
Absolutely. And it's public health best practice
Hmm.
that with any test we do, we always have to do pre-test counseling and post-test
Hmm.
counseling.
Hmm.
What do the results mean? What happens after that? Gabriella has her hand up. Gabriella, please ask your
Yes.
question.
Hi. Well, I have also a comment. I also work at a community-based organization. We are patient advocates with the Dr. Stephen Harrison program for the La Fatty Liver Foundation. And the way our community health workers network is working is through education, upstream, attacking or addressing the social determinants of health from the upstream, the let's say the cheapest way and the more widespread way to educate and come and meet the people where they are, especially now since we work in a Hispanic community setting, which are the most prone to disease yet less represented in research. So we are trying to educate them more and more about their participation in research, as well as the importance of outcomes reporting and how much it matters to have a voice in the healthcare setting, specifically for MASLD. I think the creation of diabetes prevention programs that are tailored for the Hispanic traditional foods or for any minority. No, I'm just talking from my experience, but for any community that we're working, it's so important because we cannot tailor any culturally sensitive programs if we don't ask what they need and how we can meet them in the middle instead of like, oh yeah, go for the Mediterranean diet and blah, 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 because that's not impactful. And we have to change the narrative. So I do really, really appreciate everything that you guys said. Um, my question is, how do you partner up with someone that is going to be funding sponsors for your efforts? Because I've been partnering up with many other organizations nationally. It's very hard to find something local, but at some point also my team has to keep going. We need to make it sustainable, and access to healthcare is very low for this population.
Definitely. So, like I said, we have funding from foundations local to our area, which has been extremely helpful. We do fundraising. We have a 5K, 10K that also supports these efforts because, like I said, we don't get funding strictly for testing. So we use foundation support. We get some pharmaceutical funding, mostly for infectious disease, but a little bit for here. But it's also, I mean, for this call, I should have had my operations manager here because she's the one that does the budget. And she's always like, watch the budget, watch the budget. For me, I can never say no because all of this costs, the community health workers cost, the linkage to care costs. The provider does it out of the goodness of the heart, but I give them a little something. And then you have the nurses and all these other people. And so it is hard to fund, but it's worth it. And so the one thing I would just say is that, we have a great partnership with LabCorp, and they've been phenomenal with the pricing for these tests as well. It does cost, but it's worth it. So I hope I answered your question, Gabriela. Thank you for the work you're doing. And Sandra,
Thank
too.
you.
Thank you.
Yes, you did.
Um, there's been many interesting models in public health that have been developed, like decentralized integration and devolution and delegation, etc. And I do think that the theme of this webinar is building the response from the bottom up. And our resource allocation has always been from the top, and let's see how it trickles down. But I think as community-based organizations across the country, we really need to mobilize to make the case on why it's so important to allocate resources at the community level, right?
Definitely. And also, I want to say too, before this, I was working for the Fairfax County and I Institute of Public Health Innovation for the COVID response. I was one of the individuals in charge of community investigations. And it's the testing is not just it's also the data and the findings that we have. It's so we have to be responsible too. So sometimes in public health nonprofit organizations, you don't have the taxpayer money like the county departments do, but you're expected to act like a county health department when it comes to data collection. So all of this encompasses a lot, and it also helps us. The data collection also helps us in bringing education and testing to the communities. So it's not just when people say community organization, I like to say more we're public health because we use data. We have to do the database. We have to pay the data manager, the EPI. So it's like it's coming together, but a lot more resources has to go to the CBOs because we're the ones in the community, like Gabriela, talking to the people. The doctors are not out there. They may be some, but it's the community health workers that are there reaching those populations.
I think it's such an important point because we used to describe community-based organizations as touchy-feely, carey-sherry, right?
Yeah.
And it's not just that. There is a strong component to that which builds trust and everything, but it's evidence-based. It's using technologies that are approved. It's doing the epidemiology, demography, etc., and keeping data, right?
Mhm. Yes,
Um,
it is.
so there's something else that happened in steatotic liver disease. And we certainly went through a transformation at the Fatty Liver Foundation with the change in nomenclature, but we also partnered with Sober Livers to make sure that alcohol and alcohol use disorder was part of that equation. What has your experience been, especially with the change in nomenclature? But I think it also coincides with the expansion of Health Betterment Initiative to a much more comprehensive community offering.
Well, I'll go ahead and say my opinion, but I think for our community, it's always fatty liver disease. The acronyms is just too hard for the population, even for some of the community health workers. And if they don't know that, that's why it's like you want to raise awareness. But I will always say if the name is too complex, it just kind of takes away from, the importance of why people should know about it. And so
Right.
a lot of times, if we say fatty liver disease, they can understand that better than anything else. So that's my point of view. But Shane, you can take it from here.
Oh, I totally agree. When we're talking to the public, the way, I'll say massled and mash, but then I will realize I need to talk about fatty liver because this is what they know. And as far as talking about alcohol into this conversation, there's still stigma. And we talked about with the community health workers at HBI, we talked about stigma and people, even with the name change, people still there's when somebody is told that they have fatty liver disease by their doctor, one of the first things that sometimes they say is, but I don't drink. And so I'm trying to clear that up. And that's one thing that the CHWs are telling the people also in their communities, that this doesn't, we say fatty liver, but this doesn't have to do with the alcohol. We're not putting that in the equation. It's the metabolic conditions. So I'm not
And
sure if I
that's not
went on.
easy. And that's not easy, right? Because there's stigma around fat and there's stigma around alcohol use,
Yes.
and it varies by community and it's patient by patient. So it is a combination of how we do the messaging to resonate with a particular audience, a particular community, and a particular individual based on their lifestyle, etc. We have Jen from Sober Livers, who's also raised a hand to add a comment or question. Jen, over to you.
Hi. Hi. Thank you guys for being here, and I really appreciate everything that you're doing. I worked with kind of a similar organization here when we were talking about some other, like when we were back in the COVID days and we were trying to get information out about monoclonal antibodies. And so, in trying to explain monoclonal antibodies to underserved communities was extremely difficult, and how this infusion would help you get over COVID faster. So I do recognize and I really appreciate the work that you're doing. Coming from and I have alcohol associated liver disease. I have cirrhosis. I'm in remission from alcohol use disorder, 8 years. And so that's why I founded this program. But I founded this because I felt so alone and ashamed with my disease. And you're right, the stigma is horrible. But in my opinion, the only way to reduce the stigma around alcohol is to start talking about it. And I think the fact that we're afraid to talk about it is one of the reasons why there's so much stigma around it. Because alcohol is so prevalent in our society, but we feel like if we can't control our alcohol, and I'm putting that in quotes, if we can't control our alcohol, somehow that is a reflection of us and who we are. And if you talk about genetics and the conditions that cause fatty liver and cause, someone to get in this condition in the first place, it's alcohol, it's metabolic conditions, and it most definitely is both. And if you have metabolic condition and you are drinking alcohol on top of that, you are pouring gasoline on that fire, and that patient is going to get sicker quicker. So I really believe that we need to educate people about alcohol, let them have an understanding about it, and also bring them an opening to talk about it. And having someone within your organization who maybe has lived experience with alcohol use disorder or something like that that is out there talking to the community too is extremely helpful. Because you see, if you look at me and you can't see me right now, you probably would be like, oh, this person could never have had alcohol use disorder. It's because of the stigma of what we think about. Or this person couldn't have cirrhosis because I was 46 years old when I was diagnosed. We have our first, in our community, we have someone who is 31. She's an advisor for us now, had a transplant at 30 because of alcohol associated liver disease. Women are getting this younger and younger, and women, especially Hispanic women, do not understand. I think, first of all, mine is a lot of my drinking was from interpersonal violence. And I know that this happens a lot in the Hispanic community as well, but it is very silent. And I know I dealt with my interpersonal violence by drinking. And I think the more we can educate women, especially, well, I don't want to say men, I mean, men are drinking too, don't get me wrong. But we're uncovering what women are drinking. And if we're not talking to them when we're out there, when they're buying their wine, or like that HEB, the person, I was like, oh, I put that heart out there because yeah, when you walk into those places and they're giving out wine and all this kind of stuff, you've got to have some appropriate messaging around the fact that alcohol causes cancer. Alcohol causes breast cancer. Alcohol causes liver cancer and like 8 other cancers. And to not talk about this elephant, quote unquote, in the room, I think is a really disservice to underserved communities because it is not, I don't call it a lifestyle disease. I call it a life circumstance disease. And I think if we surround ourselves in that thinking that this is a life circumstance where there is a liquor store on every corner in some of these communities, instead of a health center at every corner of these communities, that's where that problem is. And I would love to see you guys open up to the idea of sharing that information about the idea of the gasoline. You know, if you have diabetes, drinking alcohol is just going to accelerate your progression, and because that's what it does. The reason why women, and I'll stop after this and get off my soapbox, but the reason why women, I believe, are accelerating so much in needing liver transplants is not necessarily because of their MASH. It's because they are also drinking with their MASH, because we used to not tell people not to drink if they had MASH, which I think is crazy. But now the messaging has finally changed. So I'll stop there.
So
So
Jen,
Jen,
would
a
you
lot
be
of great
interested?
points.
Oh, I'm
Yeah.
sorry. I like
No, no,
Jen,
go
would you be
ahead.
interested in being a guest speaker for our community health workers? If I could get your information,
Yeah.
Absolutely.
sounds
Yeah, that would be good. And
great.
also, like, I do respect everything you were saying, Jen. And it's like we can also adapt, get more educational material out on the
Mhm.
impact of alcohol with diabetes and also related to fatty liver disease. So we can go ahead and do that and work with you as well.
Yes.
So thank you so
Wonderful.
much, Jen.
Yes.
Thank you.
Yes.
Thank
Thank
you.
you.
Yes.
Excellent. I was going to make that suggestion. And it's one thing to say, let's have the conversation, but what's really important also is how we have the conversation. And I think with the experience of sober livers, that would be helpful. But I think Jen raises another very important point is, Gabriella also raised the point on the social determinants of health.
Mhm.
Uh, Gender equity and parity, culture, economics, etc. And as part of your offering, which is also quite comprehensive, is there a social worker involved to deal with those sorts of issues that are not so much health, but looking at the social context in which people live?
So it depends. Like if we have individuals, we work within different organizations, and a lot of times the FQHCs will have a caseworker, or we will work like, let's say they need, if there's mental health, then if they have insurance, we'll work with them to talk to their primary care and then go from there. So it's like we kind of take on the role of navigator. I mean, there are times that we're helping people with their groceries. We give them incentives if they need it. We actually help them with any needs that they may have. And like I said, even if it came to they can't afford this visit or something, we will come in because we don't want to leave anybody behind. And most of when we talk about budget, most of the budget goes to these community health workers to do the work because it doesn't just stop at the test and it doesn't just stop at the outreach
Right.
event. That's nothing. It continues on. It could be weeks, it could be a month. I mean, we're working with a client since last year, so we're still
Right.
working with them. We don't drop anybody. So like whether it's working with a caseworker or sometimes they have caseworkers and we just, give them the information that we have with the permission of the client. We go from there too.
That's excellent. So it's a journey with a patient rather than a static
Yeah, it's
intervention.
not it's
That's so
not a
important.
one-time shop. It's multiple times. So like I said, months at times.
So
Yes,
I
we
can't
have to
believe
build
we,
that trust,
Yes.
yeah,
you
absolutely.
know?
I can't believe we almost at time. I do have two more questions. And there were many questions that came in on things like the difference between MASLD and MASH and cirrhosis, things like where can I find a hepatologist, etc. I want to point our participants and attendees to the resources on the Fatty Liver Foundation website, which includes Finding Help and the Wellness League, where we have a function where you can put in your zip code and it will pull up hepatologists, gastroenterologists, dietitians, community-based organizations, etc. So that would be a useful tool, together with Sober Livers and Fatty Liver Foundation and Health Betterment Initiative, where you can find additional resources and information, fact sheets, etc., around disease. But I think I would be remiss not to talk about technology. So we talk about scale up, we talk about closing the last mile and getting to patients. What has your experience been in this AI world and digitalized world on using these tools to reach patients, to keep track of their journeys, to journey with them, etc., especially when the foundation of this sort of intervention has been on that human personal connection?
So we actually, yeah, for a lot of our clients, it's either texting them, checking in on them, how they're doing, phone calls. We actually use AI for our CHWs. We have a HIPAA compliant devices. They all have their phones, HBI
Right.
phones. And so they collect a lot of information from the clients and from their experience in the journey with the client too. Because as you see, we don't just see who's got abnormal tests, who's got not normal tests. We don't see it like that. We see is what is this, who is this person, how do we keep them in care, what are they like. That helps us in creating material, but it also helps us in reaching those communities. But in the AI world, we use it more for note taking and data. But a lot of our clients just like that one-on-one touch, and if we can't reach them, we go to their houses. So that's another big we do. So we try to have that personal touch, not, and then if they like texting, we do the texting as well. We want to keep in touch to see the impact what we had. And it's always great to see something like one of our clients who participated in the program. We have Healthy Steps, which is getting people doing their testing, getting them on a weight loss plan from the provider. And one of them lost 10 pounds and they were so happy. And the CHW was happy too that they really made an impact in this person's life. And it was just by a phone call. They said, I'm so happy. We checked in on them for like a month every week, called them and everything. And they were like, I lost 10 pounds. So it's wonderful to know that you saved somebody's life because had they not reached us, who knows? Shane, go ahead.
So yeah, our CHWs also are teaching the community how to use these devices. So there's the element of digital literacy that we bring in to
Mhm,
the community. So everything Sandra said and more.
mhm.
And
Oh,
we're always growing and learning.
that's excellent. Digital literacy. So many communities need it. So I want to sum up a couple of points before I go into my last question. So we talked broadly about the social determinants of health, education, awareness. There was a really, and while we talked about scale, we also talked about retaining that nuance of culture and that one-on-one personal engagement. There was what really came through was this sense of solidarity that as community workers you have with the community, and that builds the trust which allows you to do all these interventions. I think there's a couple of follow-ups where we can have discussions further on networks of scale with, for example, supermarket chains, etc. We certainly can have a conversation about additional technologies that can be used at the point of care. that
Mhm.
would help sort of move down the path closer to diagnosis, etc. And then there's a wonderful offering on deeper engagement on adding alcohol and alcohol use disorder as part of the response and education and awareness around that. So my last question, and we'll start off with Shane and then over to Sandra, is if you had one wish for your community-based program, one or two wishes, what would that be?
One thing I would love to see is more workforce development to get more community health workers trained and get them out there because they are very valuable. And I think that more organizations could have CHWs working for them and reach more members of the community. And of course, funding. We need funding, but we'll let Sandra talk about that. So,
Well, I would have,
Excellent.
the first thing that came to my mind would be free healthcare. I mean, our job really is to make sure like that everybody has a sustainable healthcare provider and has a routine, goes to their physical checkups every year. If they do that and know how to ask the right questions, then our job is done. We don't need to be there anymore. So that's the ultimate wish is that one day like free healthcare everywhere. So that way, people have a place to go because you have insurance and when you do, you don't appreciate it. You don't go to your appointments. But then you have those that don't have, and then we have to, we fight to get them the resources they need. And that's sad. So that's what I would wish
And
for.
I agree with
and
that.
I think that aligns very nicely with what's coming out from the World Health Organization, for example, and they call it universal health care,
Yes.
that everyone has access to it because someone has to pay for it, but at least everyone having to access to that. And I think the sentiment of universal healthcare is something that all governments around the world are grappling with now. I am so moved by the work that you do, and thank you on behalf of the communities that you work with, the various collaborators, scientists, researchers, companies, etc. This is where things come alive and makes a real difference in patients' lives. So thank you so much. It's been wonderful having the two of you, and we'll certainly follow up.
Thank you so much again for having us.
Thank you so much. It was
Thank you,
great.
everybody, for listening.
Absolute pleasure. And once again, thanks to our sponsors, Madrigal, and for the team at the Fatty Liver Foundation, and for all of you who've taken the time to attend this webinar. Take care, everyone.
Bye, everybody.
Bye.